Okay. Welcome to our first online seminar from Asia. I'm today's moderator, Cindy. First of all, thank you for participation in this seminar. Due to the coronavirus situation worldwide, we have probably missed a few conferences during this few months. So I hope you will enjoy the program today. To begin with, our lecture is divided into two parts. The intellectual lecture and also the Q&A sections. So please leave your questions in the chat box. We will summarize them at the Q&A sections. I would like to introduce today's guest speaker, Professor Brian Lang from Hong Kong. Professor Lang is a clinical professor in Department of Surgeries, Hong Kong University. He's the first person in Asia to ablate symptomatic benign thyroid nodules using high-intensity focused ultrasound since 2015. To date, Professor Lang has published more than 22 papers on HIFU, and more than 500 patients have benefited from this new technology. So the topic for Professor Lang's presentation today is role of HIFU in the treatments of thyroid diseases. Welcome, Professor Lang. Please share your presentation. Professor Lang, we cannot hear you.
Can you hear me?
Yeah, we can hear you right now.
So I'll talk a little bit about the role of high-intensity focused ultrasound in treatment of benign thyroid diseases. My lecture actually is going to be not only in HIFU, but also in alcohol ablation and a bit of radio frequency ablation. So benign nodules is very common, as we all know. Roughly, clinically palpable thyroid nodules is about 5% of our population will have it. And some of these nodules, they can grow in size and cause pressure symptoms and cosmetic concerns. And the gold standard has been surgery, surgical resection or thyroidectomy. Some patients, they don't want surgery, and that's where thermal ablation really comes in. And when we talk about non-surgical options, there are a couple of options, including ethanol ablation. We also use ethanol ablation in Hong Kong at Queen Mary Hospital. We use it for recurrent cysts. So after simple aspiration, if the cysts recur, we would treat it with ethanol ablation. Or sometimes if the nodule has a very large cystic component, then we will also use ethanol ablation. Thermal ablation techniques, I'm sure all of you are quite familiar with. Essentially, there are actually 4 types of ablation techniques. One is radiofrequency ablation. The other one is percutaneous microwave ablation. Third one is laser thermal ablation. And the last one is high-intensity focused ultrasound, or HIFU. I think relative to the other techniques, HIFU is actually slightly shorter in experience as compared to radiofrequency or laser ablation. And of course, to complete the list, I'll also put radioiodine therapy there. This is also a possible treatment for patients having a nodular goiter. So what are the benefits of non-surgical options? Well, non-surgical options mean we don't remove the thyroid, but we try to shrink it. I mean, the advantages are that we reduce the nodule volume, and that will improve the local symptoms. There's no surgical scars. Unlike surgery, we need to leave a scar in the neck. It can be done as an outpatient, and the pain is very tolerable. There's no development of thyroid dysfunction, no general anesthesia. It uses quite inexpensive disposable materials. It doesn't really require much technology, actually. I think the disadvantage of non-surgical options is, first of all, you have to tell the patients that before the treatment that after successful treatment, the nodule may still be there. So even though the nodule is smaller, it would still be there in the thyroid. And it's important to have a careful cytological assessment of the nodule before treatment, because sometimes there could be a small cancer that you may have missed. You need to follow them up in the long run. So for us, we follow them up every 6 months or every year. and you need to be good at ultrasound. So I think for someone who's not trained or not using ultrasound, you should be familiar with ultrasound. And also this technique is very operator dependent. I suppose like surgery, you need a certain experience to be able to do it properly. I think for HIFU particularly, you need a lot of experience to be able to be good at this tool. The complications are rare, and I will tell you a little bit about complications. I think it is probably less cost effective in larger nodules because probably you need repeated treatments for larger nodules. And there's a chance of regrowth, and we also tell the patients. And I think the literature, there's a 5% chance that it can recur after 3 years. So this is something you need to tell the patient. For ethanol ablation, basically it's about aspirating the fluid and then introducing ethanol inside. I'll just touch on slightly. The majority of these cystic nodules are asymptomatic, but they can cause cosmetic and compressive symptoms. So the first line treatment for cystic lesions is simple needle aspiration. You can do that in the outpatient clinic. And after, if they relapse, then you can do ethanol ablation. And we also do that at Queen Mary Hospital. There's a small chance that you can cause a vocal cord paralysis in ethanol ablation, and there's something you need to be careful. The instrument is basically needle, syringe, and 99% ethanol. And the patient is positioned in a supine position, skin preparation, ultrasound guidance, needle insertion to the center of the cystic area. You aspirate as much of the cystic fluid, and then you rinse it with saline, and then you introduce ethanol afterwards. And you do that for 2 minutes, and you can press on the lesion. This is just some examples of what a cystic lesion looks like. Basically, is once you aspirate it, this is all emptied out, and you can introduce some ethanol into it. Indications, basically benign nodules which are large, compressive, or causing symptoms or clinical concerns. For benign nodules which are undergoing interval growth over time that you will need it. Okay, so that would be for thermal ablation. So any nodule which are big in size, causing symptoms of some cosmetic concern, or have some interval growth, that we will consider thermal ablating. And these are some examples of radiofrequency probes. Some of them are adjustable, depends on the length of the probe. We also do some radiofrequency ablation. This is an example. You could see that the needle goes into the thyroid and cause hypoechoic marks. The differences between HIFU and radiofrequency is that the radiofrequency, you need to move the needle. So it's all very operator dependent. It's you do that one by one until the whole of the target has been ablated. And I think a lot of literature on radiofrequency ablation. This is just one of the examples, one of the newer. This was published in February this year, comparing laser ablation and radiofrequency ablation. Essentially, they couldn't find much difference between the two. Probably radiofrequency is slightly better in the short run, but overall is actually quite similar. Okay, so I'll talk a little bit about high intensity focused ultrasound, which is probably the main reason for the talk today. Basically, it is focused ultrasound. So basically, it's the energy wave propagating into the focal zone. And I think the thyroid is a perfect organ for HIFU because the thyroid is actually very close to the skin. And so I think you do hear about HIFU of other organs, but I think thyroid is probably very applicable, very, very useful. You could see in this graph there, actually it's pretty focused. So you don't get much preheating or post-heating. It's all kind of within that focal area. And I'll talk a little bit about how you treat it. There are now different types of application for HIFU, such as early prostate cancer, breast adenomas, breast cancer, and so on. And I think recently we have expanded indication for varicose veins as well. But thyroid nodules, or benign thyroid nodules, actually is quite good. The machine that wise actually has 3 components. Essentially, it has a membrane for coating the skin. So it's a skin coating membrane, and then there is a transducer for the treatment, and also there's the imaging head. So you need 3 things to be able to be successful. And I think some of you have already seen the machine. Essentially, the blue fluid is the coolant for coating the skin. When did it start? Basically, this is one of the earliest studies on, animal studies on HIFU. Essentially, this French group, they ablate the sheep, and then after ablating, they took out the sheep and they looked at under the microscope. And you can see that there's ablation of the thyroid, the sheep thyroid, quite well-defined lesion you could see, and so they could conclude that this could potentially be a safe technique for ablation of the thyroid. And actually, we ourselves also had some experience with HIFU, and then after HIFU, we operate on the patient. You could see that there's quite well-defined ablating areas after the ablation. This patient underwent surgery because the patient has multiple nodular goiter. So even though there was a shrinkage of the primary lesion, there were other nodules, which the patient eventually desired to have the surgery. You could see there's a clear demarcation between normal and fibrosis. So the indication for HIFU, essentially simple nodules which are causing symptoms or large, and the patient is not willing to undergo surgery, or nodules which have an interval increase in size of 20% in 1 year. Our criteria for undergoing HIFU is, first of all, it's got to be benign. So sonographically and cytologically, it's going to be benign. The treatment depth has to be between 7 to 30 mm, but usually for us, most of our patients, 15 to 20 mm. Solid, we treat solid or predominant solid nodules, patient with normal thyroid function. We fast them overnight, and then we put in supine position with the neck extended. And then we give some intravenous sedation. We usually give a dose or 2 doses of pethidine and diazepam. This helps us to keep the patient still and not to move during the procedure. This is very important because if the patient moves, then there's a chance that you can burn other areas of the neck. Ultrasound examination, this is followed by novocaine infiltration. I'll talk a little bit about that. And hydrodissection, sometimes if the nodule is very close to the carotid areas, we'll do hydrodissection before treatment. And then we'll treat them. Usually we'll treat them with sequential application. So with a single nodule, we will treat them twice. Sometimes if the patient is a very small one, you can do it with single, but I think for larger ones, probably sequential is better. And then we'll put ice pack after the treatment. So I've got a video on this, so I'll show you the video. So this is just an example of how you inject the local anesthesia in the parathyroidal space. Essentially, this is the thyroid there. The black area is the local anesthesia. It actually goes between the strap muscle and the thyroid. And hydrodissection, this is an example, a nodule close to the common carotid artery. What we do is we inject fluid in the lateral area to kind of cushion the nodule before we ablate it. I think that it's important that you keep it a certain distance from the heat-sensitive areas, such as the recurrent nerve and also the common carotid arteries. Okay, this is how we do it. Essentially, this is a patient in the supine position. The patient is awake. We would use ultrasound and place the needle between the thyroid and the common carotid artery, and then we will attach the needle to the syringe. So during the treatment, you can inject 5% dextrose to increase the area between the thyroid and the common carotid artery. And so this is just an example of someone we inject some alcohol and alcohol is sometimes we use to inject within the lesion, and the hydrodissection is for pushing the lesion from the carotid. So this is just a video. The picture on the left side is the pre. This is during. You can see there's fluid. We inject a lot of fluid in the lateral area of the lesion. You could see there's an increased area to push the lesion towards the medial, away from the carotid. All right. And so I'll show you a video on how it is done.
This is a demonstration for thyroid nodule HIFU treatment.
Can you hear me?
Patient lays down on treatment bed and keeps her neck hyperextended. Inject intravenous sedation. Pre-treatment scan with ultrasound machine to locate thyroid nodules.
So when you measure the nodule, you
adjust the treatment head onto patient's neck.
Dimension as well as coronal direct dimension. And then you adjust the treatment head onto the neck, patient's neck.
Adjust the laser beam onto patient's neck. Outline skin and thyroid nodules on touchscreen. Confirm the target area. Adjust power. Start treatment. Observe the echogenicity change of the treated site.
The energy power we use for ablating. You could see after the ablation, you could see there's a hypoechoic mark in the focal area, and this will continue until all the brown circles become filled with red or with green.
Observe the treatment until all sites turn green.
So we continue until we all filled up.
Lift the treatment head after treatment is finished.
So this is
post-treatment scan with ultrasound machine.
We do another scan to look at.
Observe vocal cord.
Look at the vocal cords to look for any cord injury. In this patient, you can see the cords very well. It moves on both sides.
Observe treated thyroid nodule. Clean the ultrasound gel on patient's neck. Discharge patient to recovery room.
So patients, they have the procedure. They come in on the day of the treatment, and then they get discharged in the afternoon. So it's a day procedure. If you ask them, they have very little pain during treatment.
Apply pack onto patient's neck.
Right, so that's the video. Oh, sorry. So some pictures just show you. This is before treatment. This is the transverse view. This is the coronal view. After treatment, you could see that the nodules becomes more hyperechoic. There's some hyperechoic marks. These are actually microbubbles from the heat. You could see after 4 days the hyperechoic marks actually goes away because the bubbles goes away, and the nodules becomes more kind of hypoechoic. For very large target, we now use two different parts of the nodule to get the best results. There's some pictures of very large lesions. We use two treatment. This is a picture of before treatment, after the first treatment, after the second treatment. You can see after the second treatment, you have more hypoechoic marks. And this is just a picture showing you the treatment room that we have. It's a small room. Basically, the machine is placed on the head of the bed, and the patient's head is on that side. We give sedation, as you already seen. I think it's important that you should select nodules. I think for a perfect lesion would be something in the 15 to 20 mm depth. I think if it's too superficial, the machine actually shut off the power, and you can't really burn the very superficial one. For very deep one, of course, is very difficult as well, because you lose a lot of energy as the energy propagate down the tissues. And this is another video. Let's see if I can show you. So regarding the efficacy, I think it depends on what power you use. For this one, it's only 36. So patients, also how big the patient. I think for us, we like to have very small patients, and so it's actually quite good. This is a picture taken after treatment. You can see some redness. This redness is actually due to the balloon. That's because it's very cold balloon, and it causes vasodilation along the skin there. Well, how do you know you have done a good job? Basically, you can check the thyroglobulin, and we check that before the treatment and after 4 days after the treatment. The majority of our patients, they have an increase of about 7 to 8 times the level of the baseline level, and you know you have done a good job. And these are some pictures showing you, with along 3 months, you could see the lesions become smaller. In this patient, I think there was a 69% reduction. This is some, apart from hypoechoic marks, you could get cystic changes, cavitation changes. This is some cavitation that you may expect after treatment. So this is what you get. In this patient, you could see the thyroglobulin went up from 45 to 2000. So this patient had a very good ablation. For small lesions, they can do extremely well. I mean, for this particular patient, you could see the lesion has gone to very tiny. There was a 87% reduction in the nodule size over 6 months. These are just some more. For moderate size, they do decrease in size, but they don't decrease as much as smaller size lesions. It's 45%. This is a conglomerated nodule. In other words, there are multiple nodules within an area. You could also burn that, and we do see shrinkage in this kind of nodules. This is a patient with a calcification around the wall. Again, this patient is, you might think that the wave may not go through the calcification, but that's not true. In fact, this patient also had a shrinkage, quite well shrinkage after 6 months. So sometimes you can also treat that with HIFU. You may encounter some patients with intranodular macro calcifications. These macro calcifications actually can use as a deflector for the heat. So we would sometimes aim for the deflector, and that heat can go outwards, and that causes shrinkage also. And I think this is just an example of nodules with macro calcification. So overall, we had initially we have a 65 or 66% reduction in 12 months. And over 2 years, we do see patients with further shrinkage, although there are some nodules which can increase in size over time. And I think this is something that you should consider when doing HIFU, that sometimes some of the nodules, because you can't ablate the whole nodule, it can grow back over time. And this is just another advantages of HIFU versus other types of ablation is the fact that if the patient is on anticoagulation or antiplatelet agents, you can still do it because there's no needle track and so on, and so patients don't have any bleeding problems. And we have shown in this study that I think we've done 12 patients with anticoagulation, antiplatelets, and none of them had any bleeding problems. Are there any shortcomings? I think first of the shortcomings is that it can take a bit longer than other ablation techniques. For us, it takes about half an hour now, so it's shorter than before because of the upgrade with the software. We do see some patients, they don't respond to this treatment. Only about 80% responded, about 15 to 20% don't respond. And there's a number of reasons for that. I think that it's important that you select the right nodules for this treatment. There's some potential complications. You can get some skin color change because you can apply some heat on the skin. Skin burn is very rare, but you do see that. You can have recurrent anterior nerve injury, Conner syndrome, and also some patients with incomplete treatment. If you compare laser ablation, radiofrequency, and HIFU, you could see the efficacies are actually quite similar, at least for single application. But the treatment time is a bit longer. The lesions are a bit smaller in this series, but you could see a lot of cases have been reported for radiofrequency and also laser ablation, and less for high intensity focused ultrasound. I show you some. I did show you some successful one. I'll show you some unsuccessful one. These are some lesions which did not having complete ablation. You could see that there's some areas close to the carotid which wasn't ablated properly, and around the carotid area, around the trachea area. And so for this kind of patient, you need to retreat them. And you can retreat them, and if you do a good job, then they usually can shrink. Sometimes the lesion is very close to the skin, and that is not a good candidate for HIFU because you can burn the skin, and also the energy applied is not really good enough for ablating superficial lesions. Sometimes you do get intermediate response, such as this patient, which had a 55% shrinkage after the first treatment. In this situation, I apply a second treatment, and the lesion progressively got smaller, and eventually there was a 75% reduction. So the patient was happy. This is something you should be aware of. Some patients may have previous scars, and if you apply the head onto the scar, sometimes you can get some redness around the scar area. So it's something you should be aware of. And also we have a patient with a harness. This is temporary. Fortunately, this patient recovered from the ptosis of the heat. So what are the benefits and shortcomings of HIFU over other ablation techniques? I think you can say that this is a truly non-invasive treatment because there's no needle insertion. There's no need for any skin sterilization, unlike radiofrequency and so on. There's no need to withhold any anticoagulation. But there are shortcomings. I mean, it costs a bit of money. The machine costs money. we do give intravenous sedation because we do think that that actually helps with the treatment. It takes a bit longer. It is probably a less established technique, and you need to select the right patient for it. So in conclusion, ethanol ablation is the first-line treatment for symptomatic cystic lesion. Film ablation is very good, and for non-invasive treatment for benign nodule, it can induce shrinkage, improve nodule. HIFU is a very safe procedure, can perform as an outpatient clinic. There are some shortcomings that I already told you, like long ablation time, unsatisfactory response, and some potential complication. But essentially, it is a very safe procedure, and I think everyone should have a go. So that's the end of my presentation.
Thank you very much for your sharing. Here we have a few questions. The first question will be from Dr. Christian Volander from Frankfurt. The first question is, ethanol injection before or after HIFU treatment? Do you do ethanol injection before or after?
Very good question. Actually, we would do it before the HIFU ablation. So if someone has a mixed nodule, what you can do is you can treat it with alcohol first, and then to treat the cystic component before you treat the solid with HIFU. So for us, we would do the ethanol first, and then after a few weeks, we would do the HIFU. Of course, you can, if the cystic come back, you can always re-aspirate the fluid before you do the HIFU on the same day.
The second question is, we observed a big difference in first generation HIFU and the beam motion techniques, second generation. Therefore, and to avoid patients' motion risk, we perform HIFU under general anesthesia. What are your experience?
We haven't had any experience with general anesthesia, but I think there are pros and cons of general anesthesia. First of all, I think one of the big advantage of doing doing non-surgical treatment is the fact that you don't need to give general anesthesia. So by giving general anesthesia, you actually lose that benefit. But I can understand why some people would like a general anesthesia, because this can be sometimes may not be comfortable at times. So for us, we give very strong IV sedation. I think it's important that you keep the neck still so you can do it quickly. You don't need to reposition your treatment and so on. So for us, we would definitely do intravenous sedation. The other problem, of course, with general anesthesia is the fact that, you know, sometimes if the patient is really totally paralyzed, and sometimes you can cause some injury that you might not be aware of during treatment. And so for us, if we give sedation, if the patient moves, we would sometimes review what we're doing, and we're not doing some burning of the skin or some burning of the nerve and so on. So I think this is what I experienced.
Okay, so there is another question. May I know, do you do hydrodissections on all patients?
Not everybody. Not everybody. We don't do hydrodissections for everybody. We only do it if it is very close to the common carotid artery or the recurrent nerve, that we would do hydrodissection.
Okay.
Not everybody.
Mm-hmm. And there is one question. Have you done antibodies before and after the procedures?
Antibodies?
Yeah.
Antiviral antibodies?
Yeah.
Yes, we do. We do. We'll publish our experience on that.
Okay. Here is other questions from Dr. Christian Volander again. What about toxic adenomas?
Not a good idea. Don't do toxic adenoma. it's very difficult because you need to ablate the entire nodule, and also you need some margin. It's not uncommon for toxic nodule to remain toxic. So even though the nodule is shrunken, the toxic component is very difficult to treat. So I wouldn't recommend toxic adenoma, no.
Okay. Here is a question from Spain, Dr. Otis Ramacha. What is your sedation protocol? Thank you.
So we give pethidine, so it's like a morphine. We give about 50 to 80 milligrams. Diazepam we give about 5 to 10 milligrams. We give it in a kind of a boluses. So depends on the duration. We usually give about 5 or 6 boluses. So we give a big bolus initially, and then it takes some time. It takes about 5 minutes before the patient really get comfortable with the sedation.
Are there any limitation if you perform a second treatment on the same patient?
Any advantage? Any benefit?
Sorry, it's any limitation. Limitation
for doing a second ablation?
Yes.
Not really. I don't think that the risk is higher. It's basically the same as you do the first time. No limitations.
Here is a question from Dr. Christian Verlander again. You did Graves cases. This is a question. Do you do Graves cases?
Graves patients?
Yeah.
We did about 50 patients. Essentially, we found that around 30% responded. About 60% responded and 40% relapsed after about a year or two. So it's not a perfect treatment. We still try to work out how we can improve on the treatment. I think there's a number of reasons for that. Probably because there's some areas we just can't get close to because it's dangerous, and so we tend to leave a lot more thyroid than with the ablation.
Okay. So due to a time limitation, for those questions that we haven't had enough time to answer, we will send you through the email. And if you have further questions, you can send the email to us. We will leave the email here in the chat box later. And we will send you back the reply as soon as possible. I think this is the end of our seminars today, and thank you again for your participation. I hope we will see you again in our next examination sections. And thank you very much. And
okay.
Thank you, Professor Lang. Thank you. Bye-bye.